Thanks, Craig. Yeah, so first I just want to thank the community for participating in this first time of us doing an OHDSI challenge. Our motivation for doing this is to try to provide the community an opportunity to engage with each other, to learn and share what we are learning with each other, and to showcase areas where potentially we have opportunities to collaborate together. And this is something that we're kind of experimenting with as a community, but we thought an idea of having a short-term collaboration opportunity, in this case, this OHDSI challenge was a chance for everybody, whether you only have 10 minutes to spend or whether you've been deeply immersed in something, to have an equal voice and an equal opportunity to participate. And we're keen to try to see and create more opportunities for collaboration. So we welcome and interested to get feedback from the community about this challenge, and for those who participated, why, and for those of you who didn't, why not? What were the obstacles that were in place that prevented you from participating and engaging? But specifically, this challenge was focused on data visualization. And the reason we chose this as a topic was because I think it's, no matter what you're doing in the OHDSI community, whether you're focused on standardizing data, or you're focused on open source software development, or you're focused on methods research, or you're focused on answering clinical questions, data visualization is or needs to be at the heart of what you're doing. And I think this is an area of tremendous opportunity for collaboration and growth within our community, to think about data visualization itself as a competency and as a skill that we can all develop and learn from each other. During the context of the Charybdis work that was going on, I think Kristen was probably the most vocal on Twitter, talking about the challenges of trying to have tremendous data available, and yet having to do a lot of wrangling of data to try to create appropriate visualizations. Trying to master ggplot in R, for example. But more broadly, I think that data visualization isn't just a competency that we could work on. I think it's actually an opportunity to expand the impact of the work that we do. The data that we're collecting as a network represents the real-world experience of patients. When we talk about these data sets, sometimes it's tempting to start talking about numbers in the abstract sense. We have this data model, and we put data in the data model. But that person table is actual people. And so when George says that we have over 650 million distinct patients across the OHDSI network, we need to be thinking about that represents a tremendously large population, a population of individuals for which some of their real-world experience with healthcare has been captured. And it's our opportunity, and I would suggest obligation, to figure out how to tell those stories of those patients in the best, most effective way possible. And so we have this person table, and it has people, and it can tell us the stories of people who participate in these data sets, and it tells us about their demographics, their age, and their sex. But then we have, throughout the common data model, a series of longitudinal time-stamped observations. We have conditions, we have drugs, we have procedures, we have measurements. But each and every one of those records of data is a time-stamped observation that's telling you a story, because a patient had some experience with the healthcare system. It generated some information. And we are the ones who are trying to use that information from those patients to tell the story not only of that individual who had that experience, but to try to learn from those stories so that we can hopefully cast a new story for the next patient that's down the road. And a lot of what we focus on is standardizing the data, getting data into the common data model, or standardizing our analytics and figuring out how to produce aggregate summary statistics from these individual data observations. But every one of those patients in our data sets represents a story. It's a story of an individual and what they've gone through in their healthcare encounters. And those stories deserve to be heard. Every one of our aggregate summary statistics, that evidence that we talk about generating, the reliable evidence, that evidence is a story too. It's a story about the phenomenon that we've been able to observe across a cohort or a population. And while we've done a lot in this community that we could be tremendously proud of about standardizing data, we've done a lot about developing standardized analytics. And I think we've contributed a lot to the broader healthcare ecosystem by generating reliable evidence that has informed regulatory policy and clinical decision making. I would say that there's still a tremendously large opportunity for us to do a better job of telling the stories of the data and the evidence that we have within our data sets. And so a visualization challenge here is not just an activity that I wanted to encourage us to think about for a month, but I hope that this becomes something that becomes part of the culture and the fabric of everything we're doing, to be cognizant of the fact that we need to be able to tell stories with our data, and that visualizations is one analytic or technical solution to help us be more effective in telling those stories. So we focused this month on the COVID pandemic and the types of visualizations that we have created in the community, or some that we created as a part of this challenge, to try to tell stories. To reinforce this point, it's one thing that we have conversations pretty much every single day to talk about that the pandemic is bad. We've all suffered hardships. We've had inconveniences in our life. We've lost loved ones. We've experienced this pandemic in a very visceral way. But it's another thing to quantify that visceral experience into numbers. And so we know right now in the world that 2.79 million patients have died from COVID-19. And that number, 2.79 million, is a staggeringly large number. But sometimes you can get numb to numbers. The number itself, 2.79 million, might not actually completely tell the story. It sounds big, but even knowing that number, it's a little bit hard to even put it in appropriate context. Visualizations, though, can put information in context and can help us with actually thinking about what does it mean and what can I do with that information. So the plot you've probably all been seeing looks kind of something like this. This is the plot of deaths of COVID over time since the COVID-19 pandemic started back in December all the way to March. And you can see the daily deaths that are occurring over time. You can see that there was that first wave back in about March of 2020. And then we've been kind of continuously at this steady state. We saw an increase towards the end of the year. And now we've seen this slight dip, which makes us encouraging, except that when you see a plot like this, you recognize that while we could be encouraged that we're on the way down in terms of the deaths, the fact that we're looking at over 7,500 deaths a day around the world tells us that the task isn't over and that we shouldn't be getting content or complacent. A visualization that shows you that we're still on a general uptick from this pandemic and we haven't yet gotten to the bottom of where we need to be is the kind of information that can be actionable. So with that, I want to encourage all of you to be thinking about data visualization as a competency, as a strategy for telling the stories of the data that you have and the evidence that you're generating, and to learn from the experience of this community in terms of not only what is the story that they're trying to tell, but how are they using visualization as a strategy for telling it. As an anecdote, some of you know, like I personally, I'm really excited about data visualization because I've seen the difference between good evidence that was not useful because it was not communicated clearly, and less good evidence that was packaged in a compelling way, and it's ultimately shifted health policy decisions. And one of my personal hobbies about all of this is that I actually have a whole bunch of data visualization books. And I use them as inspiration to think about how have other people told good stories with their data, and how can we take those ideas and present them in our own space. And I would encourage those of you who are thinking about wanting to learn more about visualization, don't just look for visualization solutions in our healthcare space, or don't look for the visualization that tells the COVID story well. Look for visualizations that tell stories well. I've got this book here that's called the Atlas of Science. It says visualizing the world we know. And it's got lots of great visualizations from science and technology and social sciences and humanities, but it provides inspiration to think about what is the question that they're trying to tell, what is the story that they're telling, and how do they actually represent that in some unique representation. I have this other coffee table book called Understanding the World. And it has a lot of really cool visualizations and novel ways to depict information that's available. Now, I've got dozens of visualization textbooks over my shoulder here that I look at. But when I think about what we're trying to do in the OHDSI community, I think that what we're trying to do is to understand the world. And we're trying to generate the evidence that provides an atlas to healthcare. But we're not going to be able to do that just by building the world's largest data network or by having the world's greatest Hades package of analytics tools. We're going to do this by figuring out ways to tell the stories of the data that we have and the evidence that we have in compelling ways that gets people's attention, to make sure that they understand what is the question we're trying to answer and what have we learned from the collective experiences and the stories of the patients that we've analyzed. So with that, I'm going to turn it back over to Craig. I encourage all of you to listen to these stories that you're going to hear from each of the challenge participants. I want to thank everybody who did participate and specifically recognize those that are going to showcase their work today for taking the time to volunteer and share your insights and learning. But I encourage all of you to think about this not as the end of the OHDSI Challenge, March 2021, but actually the beginning of an area of collaboration and focus that we can all work on together to do a better job of sharing the stories of what we've learned from our data. So with that, I'm going to turn it over to Craig, and I'm excited to walk through all of the challenge submissions that we've had today.
Great, thank you very much. So on the chat, it became clear that there were a number of people that could not actually see what you were showing. So we're not entirely sure why that happened, but we'll try to figure that out in case this comes up again. But again, we will be recording this and we'll see if it appears on the recording. We'll have that on the community calls page later on. But I am going to share right now, so I'm pretty confident that we will be able to see everything moving forward. So we're going to start. You should see, I'm going to try it, Andrea Pastillo, her slide. So Andrea, are you there? And if you would like to unmute, and, you know, we're just going to leave the floor to you. What's this all about, and why did you think it mattered?
Andrea,
I know I saw you on the.
Andrea, can you hear us?
I think Andrea may have just fallen off. Oh, no, I see A. Pastillo there. Andrea, you may have to
muted.
Unmute yourself. He's probably talking into a muted mic right now.
She says she cannot. He says he cannot. He says he cannot open the microphone. Yeah, sorry.
All right. I don't know if you want to try to log off and log back on. We can move forward and then come back. Let us know if you can hear. Otherwise, we can maybe put it into the chat. I saw him move on. Let's move forward. So let's just move forward to our next one. That's Faiza Arshad.
Okay, can you hear me?
Oh, hey, Andrea.
Okay. So hi everyone, I'm Andrea from Barcelona, Egypt, and thank you, Craig, and thank you, Patrick, for your speech. Very inspiring. So, this is the figure we presented with Christine, Dani, Salita, and others for the general Charybdis paper, and I want to thank them for the very useful suggestion that they gave me. So here you can see 3 different cohorts in the Charybdis environment. So if you look at the bottom, you see the colors that represent cohort: diagnosed in red, hospitalized, and intensive services with COVID-19. And you see a proportion of people in those cohorts split by age categories. So if you look at the right side, you see men, and if you look at the left side, you see women. So we tried to sum up demographic for all these cohorts, and basically you can notice that with age, for older patients diagnosed, can you hear me, right? I see some messages.
Yeah, we can hear you.
Okay.
Yep.
So with age, you can see that diagnosed people decreases, but hospitalized and intensive services people are actually increasing. And also, if you look at the percentage of female for the diagnosed cohort, the proportion is actually higher than that male across databases. But the percentage of hospitalized and intensive services cohort is actually low. So yeah, so with this visualization, we try to sum up all demographic information, and we hope that this story about COVID people was well represented. I don't know what do you think, but that's what we try to sum up. Thank you.
Thank you, Andrea. Thank you for sharing this. This was great. Thank you for leading off our set of spotlights. We'll move on to Faiza Arshad. Faiza, if you can unmute and take over.
Okay, hi everyone. My name is Faiza Arshad, and I'm a student at the University of California, Los Angeles. I just want to start out by thanking you for having me here today. So for the March 2021 OHDSI Challenge, I chose a dot visualization from the Byrne et al. Paper titled Deep Phenotyping of 34,128 adult patients hospitalized with COVID-19 in an international network study. And I chose this particular visualization because I appreciate how it demonstrates that dots can sometimes convey information more powerfully than lines or bars can. And the purpose of this visualization is to compare the prevalence of different comorbidities and prior medication uses in adult patients hospitalized with COVID-19 between December 2019 and April 2020. So on the left side, we see a list of health databases, starting at the top with CUIMC, or the Columbia University Irving Medical Center, to the bottom with VA, or the Department of Veteran Affairs. And the number in parentheses right below the name of the database is the number of patient records provided by that database. When you take the sum, there is a total of 34,128 individuals in this data. The axis on the right side is prevalence given in percentage. And we can view this visualization as being split into two sections. The left side is conditions of the patients from up to 1 year prior, and each condition is associated with a different color. The right side is the patient's medication use from the day of hospitalization, and each body system that is affected by medication use is also associated with a different color. So as a reader, if you were to interpret this graph, it would tell you the proportion of hospitalized individuals with COVID-19 who have a certain comorbidity, like blood disease, or who are taking a medication that acts on a specific system in their body, like the cardiovascular system. For example, we can see how certain conditions on the left, like mental disease, indicated in blue, are more tightly clustered compared to respiratory disease, indicated in purple, that is more widely spread. And similarly, if you look at the medication use section on the right, particularly at the row for the SIDIAP database and at the dots shaded in olive green, we can interpret that less than 50% of the hospitalized COVID-19 patients were taking medications that acted on the blood and blood-forming organs. So currently this visualization has a rainbow effect, but I think one way in which I would experiment with it is perhaps placing the colors in a different order so that each condition or medication is more distinguishable compared to the rest. I also think it would be interesting to see a full-page version of the graph in which the dots are more vertically spread so that the prevalence percentage of each dot is clearly identifiable. And I just think it's amazing that every day new data is surfacing, and I strongly believe that the continued collaboration within OHDSI will help solve these challenges. So thank you so much for your time.
Thank you, Faiza. That was a terrific explanation and description and some ideas to think about. So, okay, let's move on to Albert Prats-Uribe. Albert, you want to unmute and take over?
Hi, thank you, Greg. Thank you for letting me show and explain why I like this graph. This graph is part of the Charybdis drug utilization paper that we did to look at use of drugs in patients that were hospitalized with COVID-19. And I think first it shows how when a lot of people and a community gets together can really get very important information that will and that help move forward policy and make changes and impact real lives. But what this graph shows is in the y-axis the percentage of people that were prescribed hydroxychloroquine when hospitalized with COVID-19. And the x-axis, you can see the months, February to December last year, 2020. And I think it was very interesting to focus just on one drug for this graph and see how it changed over time, the use of this drug. And this drug is hydroxychloroquine, because this also tells another story, that it's how in times of uncertainty, almost everyone, as we can see in this graph, do rush decisions, or we try to work with the best we have. And in this case, it was evidence that hydroxychloroquine was working in vitro for COVID. And this was amplified by fake news and Twitter and also politicians all over the world. And there was a lot of press going. But one of the important things is how after all of these communities get rigorous evidence of why this was a problem, on how this it was not backed by rigorous evidence, the rates of people who were receiving this drug started to come down, and they stayed down up to the end of the year. So yeah, I think this is a great way of telling the story of how hydroxychloroquine kind of was used during this pandemic, and how we averted probably a lot of further damage by generating good evidence about it.
Thank you so much, Albert. Yeah, this was the first paper to come out of the COVID study-a-thon, and really obviously an incredibly important one. So thank you for sharing this and reminding everybody about the real impact of OHDSI work. Another project I remember well from the OHDSI COVID study-a-thon was the cover model. I'm going to turn it over to Ross to explain and describe this wonderful visualization.
Yeah, thanks for that, Craig. Yeah, so actually I was amazed to learn from you today that it's been a year since we actually ended up producing all of this work. How time flies when you're having fun. But what I go on to explain, so this was back at the start of the pandemic. We decided to try and use all the available flu data that we had to produce a rapid response and produce prediction models for various outcomes. So these included hospitalizations, so that's the cover H model, which if we look at section 1 on the left of the graph. So cover H, hospitalization, cover I is the use of intensive services, and cover F is fatality. And one thing I think is really nice is, so we produced these, still in my opinion, really high performing validated prediction models in a really short space of time. But then the question becomes, how can you best sort of create an impact? So is this to have a tool or to have some sort of black box? And I think something that I certainly came to realize is that having sort of an image like you see before you is actually really helpful for helping to communicate these different risks. So when I've been talking to different people who have different backgrounds, so actually to try and convince my dad that he should be taking it seriously, I put him through the calculator. And he worked his whole life in healthcare, and when he came up with a risk of about 10% of hospitalization in 30 days, it suddenly for him hit home how serious this was. And so I showed him this image, and we ticked the boxes and did the conversion, and then on the right we put his predicted risk against where we've seen in the data that we developed on, and that for him suddenly convinced him, oh yeah, this is actually something that's very, very serious. But when I've spoken to other people who have either a limited medical knowledge or no medical knowledge at all, and you say, yeah, you've got a 2, 3, 4% risk. For a lot of people, that percentage of risk is sort of in their mind clicks as very low. And I think what the plot that we see, so if we look over at section 3, these are where we generally saw people get predicted risks, what percentage of predicted risk they would get. When you start to see people matching up and they see how they match up to other people, and they see that, well, actually, a 10% predicted risk puts you in a really high section, it really starts to help communicate what these numbers actually mean. Because I think for a lot of people, we'll see a number like 2, 3, 4, 5% and think, oh, it's incredibly low, it won't happen to me. But when we see that that's something like 5, 10 times what the rest of society has, then that's really, I think, really a powerful message. I also have to say that a big hat tip goes out to Albert, who unveiled his previously unknown graphic design skills to me in helping to design this. And that was something else that I learned from this process, that, sometimes people really surprise you with the skills that they have. And that's why it really brought home to me why having a community like OHDSI is so helpful for helping to communicate these different messages. So yeah, so that's, so just to sum up, so on the left, you can calculate your score by ticking all the boxes. The middle will help you convert from your risk score to what your predicted risk is. And then on the right, you can compare your predicted risk to the predicted risk that we observed in our training examples.
Thanks so much, Ross. Yeah, this was really terrific. And there is, you can see in the top right corner, a digital version of this. So Ross, if you wouldn't mind maybe putting that link in the chat so people can visit that on their own as well. But this was terrific and really helpful. I know I used it with multiple people in my family as well. So great to have that discussed. Okay, I'm going to move forward to Jintong Li. Jintong, if you would like to unmute and discuss this plot or this visualization.
Yeah. Thanks for the opportunity. Hi, everyone. I'm Jintong Li from University of Oxford. So this plot is for our study on the background incidence rates of the potential adverse events for COVID-19 vaccine. So the studies was run across 13 databases, and we are focusing on 15 adverse events also we are presented the incidence rates of the events in a age and sex specific group. So there are 13 databases, 15 events, 2, 6 male, female, and 8 age groups. So adding all these point estimates together, it's tons of points. It's around 33,000 points on the spot. So we do we did have a hard time trying to present all this information together to the audience. So here, it might not be quite clear, but on the x-axis is the age and the sex group. So from the left-hand side is a 1 to 5 group, 5 years old group, and the right-hand side is over 85 years old. And on the y is the y-axis is the incidence rates per 100,000 person years, and it should be noted that this is plotted in a log scale. So, and if we put in a normal scale, the shape might look kind of different. So the information we want to show here is that there is when we talking about the background rates, this is something that usually been used to compare with this emerging reports for the new vaccines. We now see a lot of news in the media come on the adverse events for the COVID-19 vaccine, and some of them just make people feel panic. But we want to present here is that we see, if we zoom into one single plot of single events, so we see there are huge age difference and also in the sex difference. And also we see that even for the same age 6 stratification groups, we saw there's a huge heterogeneity of the incidence rates across different databases. So the information we want to convey here is for each of the events, there are very huge within population difference as well as between databases difference. So when we hope this information could help both the regulators and the general public to understanding better what we've seen on the news is about the potential safety issue about COVID vaccine and just not be too panic on the vaccine safety, I think. So yeah, that's what we're trying to say on this plot. Thank you.
Great, Xintong. Thank you very much, and again, thank you for leading these efforts with the preprint and all this really important work. Okay, I'm going to move to Greg Klebanov. Greg, you want to take over here?
Sure. Hi, everybody. I'm Greg Klebanov from Odysseus Data Services. So I guess the idea in this graph was to try to visualize the impact of COVID last year on elective procedures. And specifically, I was really interested in seeing if it had an impact on cancer screening and mammograms specifically, which are, as you know, quite well, is a critical procedure for detection of early signs of breast cancer. And so the two databases that were used in this work were graciously given to me by actually Patrick and Christian. So there are Truven Market Scan and IQV Open claims. And what you see here on this graph essentially is the prevalence rates of mammograms across the year, 2020 specifically, is on the right side, as you can see it. And again, I was able to produce those fairly simple, actually, graphs by just utilizing Achilles in Atlas and utilizing procedure reports. So it's just knowing a couple of CPT codes and having the right data sets is actually quite easy to produce significant reports like that. And as you can see from that graph, there's a definite impact that COVID had on screening, and specifically mammograms. As you can see, quite significant dip again on the right side, which is a potential problem because could result in, I would be guessing, an increase of undetected rates of breast cancer in later months of this year or even longer than that. So actually, that could be an interesting study by itself. So I, again, just wanted to thank you, again, Patrick and Christian and Christian for their support, inspiration, and giving me access to the right data sets. Thank you.
Great, thank you, Greg. Reminder, all of these are on the the data challenge thread in the OHDSI general channel if you want to look at these. If these are a little small on your screen, we're not getting rid of them, so feel free to look. Our last one is coming from Erica Voss and Frank DeFalco. This one is an interactive one, so I am going to stop sharing, and I will let you take over.
Can you see my screen?
Yep.
Okay.
Yep.
Frank, do you want to go get started?
Sure. Thanks, Greg. So Eric and I put together this visualization titled COVID-19 Pandemic, Day 26. So April 6th, 2020 was the 26th day of the COVID-19 global pandemic as declared by the US Centers for Disease Control and Prevention. And so the visualization explores this one day in a large US-based claim system. And as Patrick alluded to earlier, we usually start by reviewing high-level descriptive statistics. So in this case, Erica will click the button. And so we could see that on April 6th, roughly 1 million people had at least one visit within the claims data. And we could take that data and stratify it by sex, age, or data density by given domain. So here we could see that there were 42% male and 58% female. And the age distribution, most people were over the age of 65, roughly 55% of them. And if we look at the data stratified across the domains within the CDM, we could see that we had 37% being conditions, 27% measurements, 19% drugs, and 17% procedures.
Okay, so that was a characterization of what was going on one day, but a lot of times when we use the data, we think about individual cohorts. So what we did is to take this one individual day and kind of apply the things that we typically look at when we're trying to find COVID patients. So what I did was I looked at Charybdis to see some of the conditions and procedures and measurements that we go after to find COVID patients. So this pivots a little bit in that now it's going to be an attrition. So as I apply the criteria, we're going to see how that impacts how many patients we find. So first, if I just look for an ER visit or an inpatient visit, we have about 40,000 patients who experience that on this specific day. There were about 5,000 people of those 40,000 who had chest pains or fever on that day. There were 221 who were tested for SARS-2 COVID, so just not positive or negative, just a test was run. There were 39 of those folks who were diagnosed with COVID-19. And there were 2 people who received ventilation. So you can kind of see, like, as we apply the criteria, the patient number gets smaller and smaller. So I think Patrick did a nice job pointing this out early on, is that each of these data points that we often look at reflect individual people's journey. And so I wanted to take this opportunity to remember my cousin Thomas. April 6th was his birthday. That was also the day that he died of COVID-19. He was 30. He loved birthdays. He loved singing and dancing. He knew all the Pokemon. And he was always happy. And we're always going to miss him. I'm sorry. But, I just wanted people to remember that COVID impacted us all differently. And, we look at these data, we look at them at, these high level aggregates of people contributing information to propensity scores. But, these are individual lives. And, it hit hard for some of our families. So, thank you.
Thank you, Erica and Frank for sharing that, and our condolences for your loss, and for anybody in the community who suffered loss. I don't really know that there's much more to say beyond this. I think that was really a powerful and appropriate way to end. So I wanted to thank everybody for taking part, for sharing, especially Erica for sharing that really heartfelt and personal story. So on that note, unless anybody has anything else they want to say, I'm going to end this call. Thank you for joining. Thank you for taking part in this. Thank you for all the work that you've done for COVID and for everything, but especially COVID in the last year. And really have a good week, and we'll see you next week.
Thank you.
Everybody.
Thank you. Bye bye.
Thank you, everyone. Bye.